Good afternoon. We'll now start the pep talk. I'd like to welcome everybody to this pep talk. Please mute yourself, but always show your video picture. Please sign in your name, your Facebook account, or email address in the chat box. Please include the names of your companions attending with you. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and end of the pep talk. As a reminder, please take the online Learning Kung Evaluation Test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link has been placed in the chat box as well as in the Viber group as well as in the Facebook group. Another reminder for those who are old-timers here, 50 OLETE certificates will entitle to 1 voucher for free ROJoson telemedical consultation, like the one shown below. Another request that I'd like to make is that those who are not planning to take the OLETE, because in that OLETE I ask for feedback to my pep talk. If you're not going to take it, I won't force you, but please type in your feedback in the chat box during the open forum. Let's now have a group picture taking before we start the pep talk proper. Okay, ready? 1, 2, 3.
Nakulog na yata.
I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I've been tackling health disorder and health issue courses. This may take 3 years or longer, depending on the enthusiasm of the participants. My pep talk today is entitled National Thyroid Cancer Awareness Week 2022. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities of thyroid cancer in their health management. The contents of this particular pep talk will be the following. When is the National Thyroid Cancer Awareness Week in the Philippines? What are the objectives? How do we observe the week, both you and me? What are the ROJoson specific contributions to the National Thyroid Cancer Awareness Week in the Philippines in 2022? What are the objectives, target impact, and target outcome of the week? And what are the focus contents of ROJoson Pep Talk on Thyroid Cancer Awareness for Filipinos? I will give you the outline on this later on. Then the last one will be recognition of the ROJoson thyroid cancer survivors and sharing of experiences. When is the National Thyroid Cancer Awareness Week in the Philippines? The Philippines, through the Republic Act number 10786, which was approved on May 2016, observes the National Thyroid Cancer Awareness Week every 4th week of September. So we are now on the 4th week. So this week we're celebrating the National Thyroid Cancer Awareness Week. What are the objectives? As stated in the Act, to ensure a meaningful observance of the week, a comprehensive public education and awareness program shall be undertaken to discuss the causes, the consequences, diagnosis, treatments, and prevention of thyroid cancer. So these are the objectives. But how do we observe the week? First, you, the lay people, okay? So you make an effort to know the causes, consequences, diagnosis, treatments, and prevention of thyroid cancer. You can do this by reading, attend lectures and talks provided by DOH and other agencies, and also my particular ROJoson PEP talk. And then after, aside from reading, aside from making efforts to know, to educate yourself, you examine your body for a possible thyroid cancer. So this week, you examine your body for a possible thyroid cancer. Do a self-examination of your thyroid gland, and then consult a physician. If you want to ask the help of a physician, ask him to have a check of your thyroid gland, or if you have symptoms of thyroid disorder. So have a consultation with a physician. If you do all this listed down here, you are empowering yourself. You are contributing to the goal of the Awareness Week, which is to lessen the number of Filipinos suffering and dying from thyroid cancer. How about me? So what are my specific contributions to the National Thyroid Cancer Awareness Week in the Philippines? So this is my contribution, the ROJoson PEP Talk on Thyroid Cancer Awareness. Okay, this is part of the Patient Empowerment Program, as well as Education for Health Development in the Philippines program. I will align my PEP talk with the objectives of the national or the Philippine program. However, I will try to make my PEP talk down to earth, meaning I'll make it as reasonable, simple, practical, cost-effective, cost-efficient, etc. Hopefully to better achieve the impact of national programs in the Philippines. I will target at least 10 Filipinos who will pass the ROJoson OSIL Olete on thyroid cancer awareness. At least 10, that will be a realistic target. So this will serve as one of my key performance indicators of my contribution. So my request is please take and pass the Olete. The objectives of my talk will be the following: to create awareness among Filipinos on thyroid cancer, one, for those who are still not aware, and then to create more awareness for those who have some knowledge already on thyroid cancer. So at least awareness on the following, as stated in the Act, in the Republic Act. Okay, the following: causes, consequences, diagnosis, treatment, and prevention of thyroid cancer. So this awareness will be measured by my Olete online learning evaluation test exercise. So please take the Olete and help me achieve my objectives. The targeted impact of my talk will be the following: through education and patient empowerment, I will try to lessen the number of people, of Filipinos, dying and suffering from thyroid cancer because of late consult and diagnosis and treatment. So I will try to promote through my PEP talk early diagnosis and treatment of thyroid cancer. The impact cannot be to save all. Mas maganda sana to save all, pero I don't think it's realistic. So it cannot be also to prevent death in all Filipinos patients with thyroid cancer. And it's also unrealistic to prevent suffering in all. As I said, this is unrealistic. It cannot be 100%. So the best would be to lessen the number, okay, which is more reasonable and realistic. So the realistic and reasonable strategy is to promote early consult and early treatment to lessen the number of deaths and sufferings among Filipinos patients with thyroid cancer. I have to confess that I will not be able to measure the impact of my pep talk today adequately, as it takes a long time to see the impact, usually years, considering that the prognosis of the course of thyroid cancer is very, very long in terms of years. Okay. What I can just do are the following: to count the number of my OLETE passers who hopefully practice what they learn in terms of early recognition, consult, and treatment, and of course, count and review my thyroid cancer survivors, those whom I have treated. Now to the targeted outcome. The previous one was on the impact, but this one will be on the outcome. This is more specific now. So my realistic target at the moment will be at least 10 Filipinos are empowered based on the OLETE results. So please take the OLETE and help me achieve my targeted outcome. The focus contents of this ROJoson PEP talk on thyroid cancer awareness for Filipinos will be the following: what is or where is the thyroid gland? What is thyroid cancer? What are the causes of thyroid cancer? What are the ways to prevent thyroid cancer, if any? Where to suspect or when to suspect one may have thyroid cancer? How to self-screen and how to do self-examination of the thyroid gland? What are the consequences of thyroid cancers if not diagnosed and treated early? What are cost-effective diagnostic tests that are usually being done for thyroid cancer? And what are the usual treatment? And what is the prognosis after treatment for majority of thyroid cancers, and especially with early treatment? So let's start with the first topic. Where is the thyroid gland? The thyroid gland is located at the front and on the central neck, middle part of the neck. Normally, the thyroid gland is not palpable or barely palpable. If you cannot palpate something in that central neck, something unusual, something bulging, then you can say that your thyroid gland is normal. Okay. But if you feel something unusual, it may mean that the thyroid gland is enlarged or there are nodules. So it could be abnormal. So what is thyroid cancer? Thyroid cancer, simply speaking, is just cancer originating in the thyroid gland. In the Philippines, these are the three most common types: papillary carcinoma, the most common, follicular carcinoma, and anaplastic carcinoma, which is the least common among the three. There are more, but these are just the three that are commonly seen in the Philippines. What are the causes and ways to prevent? So except for people with excessive exposure to radiation on the neck, yung mga X-ray radiation to the neck, okay, during diagnostic tests, but not, and also during the yung mga explosion of nuclear weapons or nuclear plants, okay, in Japan, in Russia before, okay. So except for this, the cause is usually not known. It could be genetic, but we don't know the exact cause. Okay? So anybody can have thyroid cancer with the exact cause not being established. It just appears. So when somebody asks me what's the cause, aside from not having excessive exposure to the radiation, I'll just say, I don't really know, sorry. Okay. So again, except for avoiding excessive radiation exposure to the neck, there is no other known way of prevention. Because if you want to prevent something, you have to know the cause. But at the moment, we don't know the exact cause of majority of thyroid cancer. So there's really no way of preventing. When to suspect that one may have thyroid cancer? The starting point in suspecting thyroid cancer is the palpation of a mass on the front central neck, where the thyroid gland is located. So the mass may not be visible yet, but they are palpable already. So, but it can also be visible like this. Okay. So it can be of any size and of any number, okay, whether single or multiple. So if you have something there on the front, on the central neck, okay, to say that it is thyroid in origin, so make sure that the mass or masses, if you feel more than one mass, moves with swallowing. If it moves with swallowing, or they move with swallowing, like this, okay, before swallowing, it's located here, but after swallowing, it moves its direction a little upwards, okay, but this is by inspection, but you can feel the movement also when you palpate it, okay? So if you have nodules here palpated, make sure that it moves with swallowing. Then if they move with swallowing, then most likely they are thyroid in origin. I said the starting point is that there's a mass there, because once you have a mass, actually in any parts of the body, not only in the thyroid gland, you have to consider cancer. Okay, the mass can either be cancer, not cancer. Okay, so we have to do further evaluation to check whether that particular mass is cancer or not cancer. So you don't suspect a thyroid cancer if there is no palpable mass. Okay. So a thyroid mass seen on ultrasound and other imaging studies can also prompt a suspicion of thyroid cancer. Okay. So a starting point there is really a mass. So palpate your neck regularly, at least once a month. If there is no palpable mass on the thyroid gland, then don't worry about thyroid cancer anymore, okay? So how to self-screen for thyroid cancer? My personal recommendation is to do neck and thyroid self-examination monthly starting at age 18 and onwards. Usually thyroid cancer, especially the papillary ones and the follicular ones, they usually start at a young age also. Not unlike other cancers, they usually start late in the life of a patient, of a person. Okay. So if a mass is felt on the thyroid gland, consult a physician right away. So this is how we do a self-examination of the thyroid gland. So I stand in front of a mirror, have one glass of water ready for you to drink so that you can you can swallow it and then make your trachea moves out and up and down. Okay, so to determine whether you have a thyroid mass or not. Okay. Then palpate your neck, okay, as illustrated. Use your fingers. Okay, usually one hand will be enough, but if you can also use two hands. Okay, so palpate your thyroid gland as you swallow the water. So the swallowing of water will facilitate the evaluation or assessment of the mass that you might be able to feel on your thyroid gland. So if you don't feel anything by inspection and by palpation, especially by palpation is more accurate, then you don't worry about thyroid cancer. So possible findings on self-examination of the thyroid gland, you can have enlargement. This outlines the original size. Then if there's enlargement, mas malaki, okay? Or there are nodules, whether single or multiple. So these are the three findings that you may have on self-palpation of or self-examination of the thyroid gland, usually by palpation. So if you have this one, enlargement, usually it's not, you don't suspect thyroid cancer. It's more of a hyperthyroidism or hypothyroidism. Okay, you're not talking about cancer. you talk about cancer only, as I said, the starting point of suspecting cancer is a mass. So if you have a mass here, then you suspect cancer. Okay, but if there is no palpable mass on the thyroid gland, so when you palpate your neck, okay, don't worry about thyroid cancer. Okay. If the thyroid nodule or nodules or masses is or are palpated, if you palpate all these things, then cancer is a possibility. These have to be evaluated further. So to evaluate further, if you feel a lump, okay, or nodule on the thyroid gland, okay, check whether the lumps are hard in consistency. Kung matigas, you suspect cancer. Okay, that's one of the cue for cancer, malignancy. If it's fixed, di siya gumagalaw when you swallow, okay, then you also suspect thyroid cancer. Especially if any one of these is present, no, and then accompanied by if there is persistent and progressive hoarseness of voice, paus palagi ang boses mo, and then you have a thyroid mass there, now then you think of thyroid cancer. Another possible cue for thyroid cancer would be if you palpated a lump on the side of the neck, okay, which could be a lymph node aside from the one on the neck on the thyroid gland, then you suspect thyroid cancer. Again, if you have a distant mass, yung mass na, when you say distant, malayo doon sa leeg, no? That's usually nasa scalp or any parts of the body, no? Outside the neck, then, which could suggest this, a spread situation, okay, then you suspect thyroid cancer. I will make some illustrations on this. Here, so just by looking, even without palpating, you can imagine that this mass is hard, okay, and also fixed. So once you have a hard mass and fixed mass, then you suspect thyroid cancer. So if you have such a situation, more than 90 to even 99%, it's already thyroid cancer just by looking. Another one, okay, just by looking at the mass, you can imagine it's fixed, okay. But of course, you have to palpate it. But just by looking, okay, you have already skin changes, meaning that it's fixed to the overlying skin. So just by just looking at this one, you suspect already thyroid cancer. Okay. This one is you have a thyroid lump now here in the central neck, and then you have another lump here, which could be lymph nodes. Then you also suspect a thyroid cancer. Suspect pa lang, ha? It's not proven to be a cancer yet, but you have to suspect thyroid cancer. Another one, if you have distant mass, ito sinasabi ko, distant mass, malayo sa neck, no? But you have thyroid mass here, plus a distant mass. Kung i-connect mo yung dalawa, this could be a spread. From here, it goes there, okay? So as we know, the behavior of thyroid cancer in general is that it can spread to other parts of the body. Okay. So in the absence of cues of malignancy, kung wala yung cues na hard consistency, fixation, no persistent hoarseness of voice, no lymph nodes on the side of the neck, and no distant mass, then most likely it's not cancer, it's benign. Okay. So fortunately, majority of thyroid nodules are benign. As high as 80 to 90% are benign. Okay. What are the consequences of thyroid cancers? So what will happen if you let it alone there? So it can have continuous growth, and then it could invade the surrounding tissues. That's why we talk about hoarseness of voice, and then sometimes suffocation. Okay, cannot eat, cannot swallow anymore. Okay, then spread to the lymph nodes on the neck and also to the distant organs, and eventually it can cause death. So this is an example of a thyroid nodule which was left untreated, no, unattended. So it grows bigger and bigger, okay, to that size. Okay. Multiple nodules, most likely the neck nodes are involved here already. Okay. And then, as I said, there are three types of thyroid three common types of thyroid cancer: papillary, follicular, anaplastic. Okay, so papillary thyroid cancers have a behavior that it usually spread via the lymph channels. Okay, lymph nodes on the neck. When you have lymph nodes on the neck and then you have a mass on the thyroid gland, most likely it's papillary thyroid cancer. Now, follicular thyroid cancers usually spread via the bloodstream. Okay. If you see a patient like the one that I showed you earlier, the one on the scalp, okay, on the head part, there's a mass there, then most likely it's follicular cancer. So the most common site of distant spread or metastasis will be on the bones and on the lungs. The third type, which is, fortunately, this is not so common, okay? So it's called anaplastic thyroid cancer. It usually occurs in the elderly patient, and usually it causes suffocation as early as in a short period of time. Malaking-malaki na, mabilis ang growth, and then it will cause difficulty of breathing and also difficulty on eating. So this is usually recognized as anaplastic carcinoma. Okay. So the lesson here is that early recognition, diagnosis, and treatment are of prime importance to avoid suffering and death from thyroid cancer. Okay, so we want to, when you have such a situation, we don't like it to progress to such a picture like this, a person suffering, and also like if you saw a mass like this already, have it treated right away. Okay. What are the cost-effective diagnostic tests that are usually being done for thyroid cancer suspect after physical examination? So usually the procedure is to do the palpation first before doing tests, not the other way around. Okay. So the usual cost-effective diagnostic tests are the following: ultrasound of the neck and thyroid gland, and also needle biopsy. Now, here is a note that tells you that thyroid function tests in terms of FT3, FT4, TSH are not diagnostic for thyroid cancers, but these are commonly being done. Okay. So take note of that. So you may not need that because if you do it routinely in patients suspected for thyroid cancer, you're just wasting your resources. Okay. So what are usually being done for patients with suspected thyroid cancer will be ultrasound and needle biopsy. Okay, this can be done first, usually done first, and then needle biopsy. Or if the mass is very obvious, then you can do the needle biopsy first. Or just to do the needle biopsy before the ultrasound. Okay. So this just shows how ultrasound is being done. Okay. So ultrasound of the thyroid gland is being done left and right nowadays. Okay. So the things that I won't go into the details, okay, how to interpret it. Just want to tell you that be wary of the readings because there's a new reading system which becomes very, very complicated. And then there are a lot of alarming reports coming out with that new reading system. Okay. So make sure to have a thyroid clinician specialist interpret the results for you. Okay. Not just take the readings of the ultrasonographer as is. It has to be correlated with the clinical findings. Needle biopsy, this is how it's being done. Just a syringe and then a needle here, hypodermic needle, just poke in the needle into the mass and then aspirate it and then get some samples here. Okay, if it's solid mass, you can get cells to be examined. If it's sometimes it contains fluid, then you get fluid. Okay. What are the usual treatment? Surgery is the primary treatment for thyroid cancer, whatever it is. Follicular, papillary, anaplastic. Anaplastic, usually humahabol mo pa. If it's too big na, surgery might not be able to be done anymore. Okay. But for papillary, follicular, usually in the earlier stages, kung di pa talagang malaking-malaki, then surgery is still the saving grace. So the surgery may be subtotal or total thyroidectomy, meaning removal of the whole thyroid gland with or without neck dissection of the lymph nodes, depending on the extent of the cancer. If there are lymph nodes present that has spread from the thyroid gland, then a neck node dissection will have to be done. After surgery, the physician will decide whether you need additional radioactive iodine treatment. Okay. And then, especially for anaplastic carcinoma, in which, as I said, when the thyroid mass cancer is not operable already in the late stages, then some would just give ROJoson just to palliate, but usually it ends up futile also. Okay. So the best way to catch the thyroid cancer is to do surgery as soon as possible. What is the prognosis after treatment for majority of thyroid cancer and with early treatment? Okay. So it depends on the type. As I said, there are three types: papillary, follicular, and anaplastic. This has a worse prognosis. Okay. Fortunately, it's not as common. And because you can see here that the 5-year survival rate is only 7%. Okay. Whereas the 5-year survival rate of papillary and follicular cancer, it can be as high as 97 or even 99%. Okay. So this one has the best prognosis, and it's the most common, fortunately. Okay. So for follicular cancer, although this is the second most common, but usually yung survival rate will be approaching that of the papillary thyroid cancer, usually in the vicinity of 90, 98, 99%. Okay. So go for early recognition, diagnosis, surgical treatment of thyroid cancer to have a better chance for cure and to avoid unwanted suffering and death. I'll now go to the ROJoson Registry of Thyroid Cancer Survivors, and I'd like to recognize them. Okay. So to better convince you of the importance of early recognition, diagnosis, and surgical treatment, and of course, to inspire you, I will now present to you my Registry of Thyroid Cancers, whom I have treated from 1982 up to the present. That's about 40 years. Okay. The criterion for inclusion in this registry will be those with at least 10 years in remission after a thyroid cancer. I would have to say that this is just a partial list because I just got this registry as they come in, as they come in for follow-up after 10 years. Okay. A lot of these thyroid cancer patients that I operated before, I cannot remember how many already, probably 50, 100, I don't know. Okay, so I usually lost them to follow up. They don't follow up anymore. So this one is just a collection of those who came back to me after the operation. So far, as of today, I have 25 thyroid cancer survivors in the registry. This can be seen in these two websites, the detailed information that is seen there. So the range of remission, meaning those practically cured neto, okay? Range of remission is from 10 years to 40 years. As I said, the lower limit of follow-up would be 10 years. If they are 10 years in remission, they're included into the thyroid cancer survivors. Okay? So 11 has 31 to 40 years in remission. So as I said, with 31 to 40 years, practically cured na yan. Okay. So 5 has 21 to 30 years in remission, and 9 has 11 to 20 years in remission. I have only one documented to have died of recurrence out of that probably 50 now. Okay. So this is just the registry only contains 25. Just double it, 50, let's say 50 cancer patients that I had in the past. Okay. So only one has been documented to die of recurrence of thyroid cancer. This is under my experience. But she was able to live for about 12 years after the operation. Then there was a recurrence. So this is a list of all the patients. I want to read them one by one anymore that you can see 40 years in remission, 35, 35, 34, okay, 31 years. Okay. And then the other list is that, okay, from 11, 10, 16, 17, up to 29 years. Okay. So Ida, I thought Ida is 34 years in remission as of today. Letty, 31 years. Bell, 34 years in remission. And then Virgie, 34 years in remission. Nelida, 29 years in remission. And then Ramona, 21 years in remissions. Marjorie, 19 years in remission. And then Alicia, 19 years in remission. Nancy, 17 years in remission. And Leonie, 33 years in remissions. Okay. So after recognizing all those cancer patients, I hope I have convinced you of the importance of early diagnosis and treatment. So let me conclude this by giving a summary and takeaway. So I've discussed all of these topics here. I want to read them anymore one by one. And then I have also discussed the following specific topics on the thyroid gland itself, thyroid cancer itself. Okay. So takeaway in relation to patient empowerment, knowledge is power. It gives power. Use the 4 Ks of patient empowerment, kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of oneself by knowing the fundamentals and generalities of thyroid cancer in their health management. So with that, I end my pep talk today. I hope I have empowered you to have a better understanding of the fundamentals and generalities of thyroid cancer in your health management. And I hope that I have convinced you to have early recognition, early diagnosis, and early treatment if you got a thyroid cancer, okay, which we don't know when you're gonna have it. Sana wala. Okay. Okay. So take the Olete to have a mastery of learning. As I said, my key performance indicators for this particular talk will be 10 Olete passers. I hope I can get 10, at least 10 passers. And then 50 Olete certificates when it's entitled one to voucher for ROJoson telemedical consultation. And then again, the request is that you type in your feedback in the chat box. Let's now have a group picture taking before we start the Q&A and interactions. Okay. So let's have a group picture. One. Ready? 1, 2, 1, 2. May pahabol showing their pictures. Okay. Last call. 1. May pahabol pa. 1. Okay. Raul, sige, pahabol. Sino pa? Pahabol. Okay. 1, 2, 3. Okay. So the floor is now open for anything, questions, interactions, as well as free consultations, basta short consultations pwede rin. Na? Okay. So we still have about 20 minutes.
I have a question.
Okay,
This is Susan.
Go ahead, Susan.
Yeah. Okay. I have a question. I had thyroidectomy in 1998. It was papillary carcinoma. And after that, I had radioactive REI. Oh, okay. Since then until now, it appears I was in remission. But I have to see an endocrinologist regularly. Well, I miss seeing the endocrinologist for quite some time. But starting 2 years ago, I saw a new endocrinologist. I noticed, Doc, that you said that an T3, T4, something like that, no, in your lecture, it's not necessarily useful. Why is that so?
It's not entirely what?
Not necessarily useful. T3,
Ah,
T4, or if did I get it right? Because I always, every time I see my endocrinologist, I have to show him the result of my T3, T4, TS8, something like that. Now, I'm gonna see him again this October, and he added in the exam a neck ultrasound.
okay. So are
If
you
I were
taking,
to choose, yes, if I were to choose, do I forego the T3, T4, TS8?
are you taking medications? I suppose you're taking medications.
Yes, he said it's for life.
Yeah,
It's
levothyroxine.
Tidine.
Levo,
Yeah,
okay.
Tidine. Oh, that's brand name, I
Yeah,
suppose.
Tidine is levothyroxine.
Tidine, 100 milligrams every morning.
How long have you been taking that?
Uh, since,
Same dose?
since, excuse me?
Same dose, same dosage
Yes, 100.
for 1 year, 2 years?
More than 2 years.
Okay. Okay, so ganun yun, ha? Okay, so you caught a segment of my lecture that I mentioned it's not indicated for patients with thyroid cancer, no? The context is like this, no? Once you have a patient, this situation is that you have not yet been treated, okay? You suspect something there, okay? So if the doctor suspect thyroid cancer, usually you don't have to do the test because thyroid cancer does not produce hypo or hyperthyroidism. But if you are suspecting something else, not thyroid cancer, but hypo or hypothyroidism, hyper or hypo, then that's the time you take the test. Because as the name implies, thyroid function test, it tries to determine the function of your thyroid gland. Okay. Okay. When you say function, it's in terms of hyper or hypothyroidism. But if you have a nodules, you're talking about whether it's cancer or not cancer. So usually when you have a nodules, whether it's cancer or not cancer, usually the thyroid function test is normal, euthyroid. That's why I said it's not really not necessary. It's not necessary because it's just waste of resources. No? But if you have been treated with total thyroidectomy and RAI, no, and then you're being given levothyroxine, Tidine, sometimes the doctors will make a monitoring of the level of your thyroid gland kasi natanggal na di ba? Natanggal na, and to check whether the dosage that is being given to you is enough or pwede nang bawasan, no? Ganon. No? Okay. So the thyroid function test that you're taking right now is after the treatment. No? So you really need the thyroid levothyroxine. Okay, because kung wala kang levothyroxine, you end up with hypothyroidism. Kasi tinanggal na yung buong thyroid mo at sinunog pa ng RAI. So you need a replacement. No? Okay. So the thyroid medications that are being given to patients after thyroid surgery for cancer have two purposes. One is as a replacement, kasi tinanggal na lahat, you have to have thyroid hormones. And then the other one, at times the doctors will use it to suppress, to make it an attempt to prevent a recurrence. Okay. So there are two different purposes for the thyroid hormones. That's why you have some monitoring of your thyroid function test. No? So I guess don't stop it right away. Just ask your doctors na lang So what do you think what purposes are you are, are the thyroid hormones being given to me? Tanong mo na lang. If it's for suppression or is it for just for replacement? No? Okay.
What if it is stopped? What's gonna happen to me if it is
If you
stopped
stop it,
and I don't have a thyroid gland anymore?
hypothyroid ka na. Hypothyroid ka na.
Hypothyroid, will it affect my heart?
Your whole body will be affected. Not
In
only
what way?
the heart. You'll be parang may slow movement because the thyroid hormones control the metabolism of our body. No? If you have no thyroid hormones, then your metabolism will slow down and everything will just follow. No? Okay?
Thank you, Doc.
You're welcome. So ask your doctors, do not just misinterpret my teaching. Okay. Ask your doctors first. No? Okay. So you are cancer survivors, huh?
Yeah, I'm a cancer. So I mean, after 1998, and I'm still
But
alive. So
yeah, see, okay, that's an example of a good prognosis for patients with thyroid cancer. How old were you then? When 1998?
I must be line of 3.
30 something lang? Okay.
Yes, yes.
Okay. Usually maganda yung prognosis ng mga bata when they get operated on. No? That's why I'm asking. No? Okay.
No, yeah, Doc, but the operation had a little side effect, and the doctor told me my voice will be a few decibels lower, which is really true. I used to have a nice voice. I could sing well, but after that, I think it was a 6-hour operation. As far as I'm concerned, it is 6-hour operation. Wow. And then to be told by the doctor that there is a good news and a bad news. The bad news is that I had thyroid papillary carcinoma. The good news is that it is not that fatal. I will live longer, which is true. Because you said,
Okay lang.
as you
Okay
said
lang.
in your lecture, yes.
Okay. So lahat ng operations may possible side effects. That's a small price to pay lang naman. Okay. So at least hindi na totally yung boses mo. Okay.
Yes, okay.
Okay.
Okay, thank you, Doc.
Congratulations, you're a cancer survivor. Okay. So any more questions? Anything in the chat box?
There is none.
Okay. Anybody else who want to share experience? What is the difference between hyper and hypothyroidism?
Hypothyroidism. Yeah, from Melingo.
So, ganun yun. Yung sa hyper, sobrang dami, hyper. Hypo, sobrang konti. Okay. So when you say hyperthyroidism, the thyroid hormones is secreting more than the normal level of amount of thyroid hormones, kaya hyper. No? Then if it's lower than the normal amount of thyroid hormones which should be secreted by the thyroid gland, then you call that hypo. Kulang naman. Kulang. No? Okay? Okay? Hyper and hypo.
Ano, Doc, effect sa daily living pag hyper or hypo?
Hyper, so just equate it simple, parang simple equation ng metabolism. So tataas yung hypermetabolism mo, so yung heart rate mo tataas, then papawisan, no? Okay, papayat ka na papayat, no? Okay. So hypo naman, medyo palagi kang pagod, palaging mabagal ang kilos mo, no? So yung mga ganon.
Tataba, Doc, yun. Tataba.
Tataba. Okay, hypo.
Okay.
Okay.
Thanks, Doc.
Any more?
Yeah, may I ask, when you're doing thyroidectomy, you're suggesting patients to do subtotal and total thyroidectomy. What is the difference between the two? Why do you suggest subtotal, the other you suggest total thyroidectomy?
it's not suggesting, it's giving them the options, no? Whether total or subtotal. When you say total, tanggal lahat yung thyroid gland mo. Yung thyroid gland mo, di ba, may two lobes, may two big lobes, right and left. So pag tinanggal mo yung dalawang big lobes, you call that total, no? Then subtotal means more than and less than the total, no? It's either one side or 1 1/2 on the other side, no? Okay, so yan ang subtotal. Now, the indications for such an operation of the operation will be depending on the extent. Kung yung thyroid cancer mo is involving the two lobes, yung right and left na lobes mo, then you're forced to do a total already. Okay. Now, if it's just confined to one lobe lang, saka maliit lang, you may do a subtotal. Lang, no? Okay. But in the moment, magulo yung literature, yung mga kahit na maliit lang, pinapatanggal nila yung buong thyroid gland total, no? Okay. So may controversy pa diyan, mga discussions, no? Okay. Some would say but pwede ng conservative na subtotal lang for small lesion confined to one lobe, no? Pwede na. Some would say tanggalin na lang lahat para wala nang umulit dun sa kabila, no? Ganon. Okay, and then some would also give RAI to treat the patients after the operation para masunog lang lahat, no? Okay. Now the significance of these two will be mas mataas ang complication rate ng total thyroidectomy. Okay, practically in terms of hypocalcemia kasi madadali yung hypoparathyroid mo, na malilit lang yon, no? So, there are parathyroids at the back of the thyroid gland. Kung dalawa ang ginalaw mo, so mayayari lahat, na baka mapasama yung sa pagtanggal, no? Compared to one side lang, may maiwan pang dalawang parathyroids on the other side, no? So, yan ang pinaka-crucial difference between the two, no? Okay. Of course, when you do subtotal thyroidectomy, you don't need replacement. Okay. Okay. Kasi meron ka pang adequate amount of thyroid gland left behind that will secrete normal amount of thyroid hormones. Pero kung total thyroidectomy, practically zero thyroid hormones na ipoproduce mo, so you need a replacement. Lifetime replacement na yon. Okay?
Okay, got it. There is a question from Rona Magpok. Hi po, Doc. Malaki po ba possibility of thyroid cancer recurrence? Ano po ang percentages?
Thyroid cancer recurrence.
The percentage.
Number one, depends on the type. No? Okay. Papillary, follicular, and let's just talk about papillary follicular na lang. Okay. So, whether papillary follicular, you use the word possibility, di ba? So, anything is possible, no? Okay. So, there's always a possibility of thyroid recurrence, whether the recurrence could be on the local, do sa gitna, central neck, or kung papillary yan, baka may mag-recur doon sa side, yung sa neck node. No? Kung follicular naman siya, pwedeng mag-recur doon sa distant, no? Sa malayo. No? Kasi yung follicular cancer, they usually spread through the bloodstream. No? So kung at the time of the operation of the follicular cancer, baka may maliit na nag-spread na doon sa, let's say, sa bone, no? So kahit na tinanggal mo na yung lahat na thyroid doon sa neck, no? So pero may nakalabas na doon. So over time, baka lumabas din yon kung hindi mo makontrol with other treatment like RAI, with medical suppression, no? With yung mga gamot, no? So pero usually, okay, ano ang percentages? How do I answer that? Kasi depende sa ang daming factors, you know. So kung natanggal lahat by the surgeon, okay, And then, kung anong kung ano yung type, whether it's follicular or papillary. Okay. So as I said, mas pinakamaganda yung papillary, mas mababa ang recurrence, no? Mas mataas yung follicular compared to papillary. Okay. And then, of course, in terms of yung yung behavior ng cancer itself, which we can never predict, no? Okay. Kanya-kanyang ano yan eh. Parang yung sinabi ko yung isang pasyente na namatay after 12 years, no? Papillary lang siya eh, no? Okay. So but for the other patients that I have, nakikita nyo, no? Maganda ang prognosis. They were able to survive 34 years, no? So it just shows that its cancer has its own behavior, genetic behavior. May kanya-kanyang ano yan, which we can never identify. No? Okay. Okay, Rana, would you like to tell your experience, share? Para ma-enlighten lahat ng tao dito.
Ay, hindi. Ay, good afternoon po. Ay, ayan. Opo, ay nagkaroon po ako ng mass dito siguro po 2018, pero hindi ko po masyadong iniinda until lumaki po ng lumaki. And then yun pong naging parang needle biopsy po yung initial kasi nagpa-check po muna ako sa neck throat po na specialist. And then from the biopsy dun po nakita na yun nga po na may malignancy. And so there was the advice for surgery. Tapos dun po ako na refer po kay Doc Joson, and then it was yung total thyroidectomy plus radical neck dissection in 2020. Mga 1 month before yung lockdown. Buti po hindi kami inabutan. Ay, one week. I mean, 1 week before the lockdown. March 3 po.
Swerte tayo, no?
Opo, kung nahuli pa po tayong 1 linggo, inabutan na tayo, baka ewan ko po kung kailan na nangyari. Thank you, Lord. So, yun po. Parang 4 days lang, 3 days lang po ako sa hospital, and then yung follow-up check-ups with Dr. Joson. So far, yun po, yung palpation dito, tsaka sa neck. So, from the last check-up, parang wala pa naman po. Ay, wala naman.
Wala.
Wala.
Wala. Okay. Okay. So, thank you for sharing. No? So, Rana is just about 3 years. 3 years po.
Opo.
Okay.
Yung pangarap ko po masama dun po sa listahan nyo.
Yeah, you will. Huh? Si Aida is not here. Aida Antonio is already 34 years. 34 years in remission. Pareho yung sa iyo, no? So, may neck dissection din. May neck dissection din kay Aida, no? Okay. So, yung sa iyo may neck dissection din. So, I think you will, no? Okay. So,
There's another one from Jocelyn P. Regarding my chronic hot flashes, open close parenthesis, 10 years, does it have something to do with my thyroid glands?
hot flashes usually connotes in ano di ba? Connotes
Menopause.
yung estrogen deprivation, ganon. So usually hindi siya connected sa thyroid gland. Unless yung very rare case, yung hyperthyroid, parang metabolism, mainitin ka, no? Meron ka bang hyperthyroid? Kung walang hyperthyroid, most likely, it's not connected. No? Okay. Okay?
There's a comment from Ate Chuchi. Congratulations, Doc, for having so many survivors of thyroid cancer.
Thank you. Chuchi is back now. Or
Yeah.
Chuchi, you're in the States?
Maybe she left now.
Okay. So we have not been hearing from Chuchi because she went abroad now. But I'm glad she's back. No? Okay. So I don't know how many cancer survivors, yung talagang survivors actual number. Pero mahirap kasi i-follow up eh. No? Okay, hindi sila bumabalik. No? Okay. Si Rona will be on the 3rd year pa. Pag umabot ng 7 more years, kasama na siya sa survivor list. Okay. So any more questions? So yung iba naman, as I said, majority will be benign. No? So some of you will have benign. No? I can see some people here. Belet Del Rosario, benign yung sa iyo, di ba? MCAG. So no problem. Delhi, benign din. No? Multiple colored adenomatous goiter, benign. Sino pa bang benign dito? Okay. Kay Jeng De Castro, benign. So no problem. No. Sino pa bang may thyroid dito? Si
May
Brenda.
question po ako.
Sige, kaya nga, Belet, di ba? Sabi sa benign sa iyo. May tatanong ka?
Doc, ang pag-take po ba ng levothyroxine ay lifetime din kahit benign?
Yes and no. It depends on the doctors. Okay. Okay. So yung sa akin, usually lifetime, para hindi lang siya lumaki, para hindi siya umulit, no? Ganon. Okay. Kasi pag tinanggal mo, baka umulit siya eh. O lumaki. No?
Pero yung pong dosage lang ang nababago.
Yeah, kaya nga. Kaya
Yung po ang binigay niyo sa akin ay 200. Ngayon po ay 150 na.
Yeah. I'll try to give the lowest possible dose. Kaya kumisan tinatitrate ko, no? Kaya Susan, usually kumisan tinetest ko yung ano niya, yung T4 TSH niya, paminsan-minsan, no? To check kung if I can lower the dose already. No? Okay. Okay. Sino pa ba yung benign?
Ay, doktor.
Benign ka rin, di ba? Okay.
Multiple coloid adenomatous goiter. Pero bakit, doktor, pag nagpakuha ko ng TSH, minsan kulang yung gamot ko. Every 3 months ako nagpupunta sa endocrinologist. Hindi pa siya nag-normal. Bihira siyang mag-normal yung TSH.
Meron akong pinost yan na yung mga results sa mga TSH, thyroid function test, nagpa-fluctuate. Kaya kumisan, ingat lang kayo sa readings. No? Okay. So that's why kumisan, I have to correlate it with yung clinical findings mo, kung anong nararamdaman mo, to say kung tama ba yon o mali, no? Ganon, no? Okay. So,
Kasi
yeah.
pag pupunta ako sa doktor, nakita na ganon, dinadagdagan yung gamot ko o kaya iniiba-iba. Minsan, uminom ako ng 100.
Kung matagal ka na umiinom with a certain dosage, wag ka na magpa-test, pabayaan mo na lang. Basta lowest dose na yan. No? Okay. Kasi kung minsan malilito ka lang din sa mga test results eh. Nagbabago eh. No? Nagpa-fluctuate siya. No? Okay.
Palaging minsan mataas.
Okay.
Opo.
So Raul, kumusta na yung thyroid nodule mo, Raul? We have the Raul Lasso with us. Thank you for attending. Sino pa ba ang bago?
Doc, okay naman. Same size and hindi naman lumaki, hindi man lumiit. Same.
Okay, good. Maintain mo lang yung gamot mo para huwag lang lumaki.
Yes, Doc. Minsan nawawala or parang tapos minsan nandyan na naman siya. So, tapos parang galaw ng galaw eh. So, wala naman.
Yung mga benign ones, minsan hindi siya talagang nawawala. But you just leave it there. I-monitor mo lang. No? Okay.
Yes, Doc. Opo.
Kasi yung iba naman, kasi iniisip nila, ayaw mawala, patanggal ko na kaya. Diba? Okay, yung mga ibang doktor din, ayaw mawala, patanggal mo na. Okay. So, pwede pang basta sure tayo na benign na babantayan na lang. Bantayan na lang. No?
Opo.
Okay. So any more? 3:10, last call. Kung wala na, we'll call it a day. Thank you for attending. I hope you will take the ulete para may at least 10 ako, may 10 passers tayo. Okay. And then the next topic, next lecture will be yung fruit seed, yung buto ng mga prutas. Is it harmful or not? No? So that will be the next topic. No? Okay. Siningit ko lang itong thyroid kasi sabi ko nga, yung fruit seed ang ile-lecture ko this week. Siningit ko lang ito because of the consciousness week. No? Okay. Okay.
Thank you, Doc.
For no more questions, let's call it a day. So,
Bye.
bye-bye.
Thank you, Doc.
Bye-bye.
Thank you so much po.
Bye-bye.
Thank you, Doc. Sorry, late po ako.
Thank you, Doc.
You're welcome.
I will take the ulete.
You will take the ulete and pass it.
When is it? Tonight? When is it, Doc? Tonight?
Anytime, basta before next Friday. I usually
Okay.
letter
Okay.
on Friday.
Because because I might forget what was stored in my mind an hour ago.
Yeah, you take it. You have the link. You have the link there.
Yeah. I have a link.
Okay, you take it now para fresh memory mo.
I just have a visitor, 2 visitors here. When they leave, I'll take it.
Anong pinapa-check up mo sa akin dati?
Yung dito sa breast.
Sa breast, hindi sa thyroid.
Oo, kasi no, it's not. Yung sa breast kasi noon, yung mammogram plus ayun pala dalawang nag-check pagkatapos kinabahan ako. Sabi ng friend kong si Norma Adamos, I asked her for a referral doctor. She said, you go to Dr. ROJoson, he's good. Sabi ng pagayan. So I went to see you.
Okay.
But I'm gonna see you again because I haven't seen you for 3 years.
Okay. Good.
Okay, thanks, Doc.
Okay, sige. Bye-bye.
Thank you. Bye.
See you.
See you.